All right. Welcome all, welcome all. And as folks are coming in from the waiting room, wonderful. Thank you so much, Jim. Welcome, everyone. My apologies. Mike Fox, I'm Deputy Executive Director of PDA. Long story on the mask, doctor's orders. In any event, thank you all for being here, and I apologize if it's off-putting in any way. Um, Thank you for being here for a very special Healthcare is a Human Right call we have going tonight. This is the regular monthly meeting of our Healthcare is a Human Right issue organizing team. So please do plan on swinging by with us each and every month. And we're just getting rebooted, so I need to look at the calendar. Second Tuesday, yeah, second Tuesday of the month. We'll be tossing into the chat the link to sign up for next month's as well. And as you're coming in, please do type your name and where you're calling from in the chat. We just like to get a feel for where folks are coming from, as it were. Good to see you, James and Scott and Dorothy and Carol and Carlos. Just with Carol and Carlos, I know we got California and West Virginia covered. We're doing coast to coast here, as always, on a PDA call. And we're just going to hold here for just a couple of minutes, gang, to allow, excuse me, all of our later arrivals to make it in. Then we will get started. We anticipate an absolutely information-packed and inspiring meeting here this evening. We're going to learn not only a lot from our speakers, but likewise, we got several to-dos that we'll be discussing. And like with all PDA calls, there is a to-do or 2 or 12 attached. So thank you all for not only being here with love in your hearts and in solidarity with healthcare as a human right, but likewise, thank you for doing after we close this call. And let's hold for just maybe another 30 seconds. We still got a lot of people coming in the waiting room here. Uh, I love my progressive brothers and sisters like nobody's business, but some of them have a little problem with the right angles and clocks on occasion. So nothing but love in the room. We'll allow them getting in the room here before we start this meeting for real, as it were. And while you're typing in the chat, all the new folks, type in the chat your name and where you're calling from. And if you'd likewise, briefly, please, because we've got a lot of people here and we don't want to fill the chat all up, but if you just got like a 10 to 20 word statement on what it is you're doing for expanding and improved Medicare for all, healthcare for all, whatever anything that makes our people healthier. Toss it in the chat if it's action oriented, like we're all going to be a part of the events on the 14th. So if you are planning on proudly presenting for healthcare at one of those events, please do mention that in the chat. All right, we're 3 minutes in here, so I say let's make this for real, and let me toss this over to Donna Smith. Donna Smith?
Thank you very much, Mike, for getting us kicked off. I also noticed Alan Minsky, our executive director, is here, so hope we can co-host him so that he can say some. Yep, thank you. Thank you all for joining us tonight. We have a really important call, I think, tonight. I thought about this topic a lot as I've talked with my own providers about healthcare in recent years. I'm lucky enough to have survived cancer of the uterus. So I think one of the guests we have tonight knows an awful lot about that topic, I think. And I'm going to share a little bit about why Dr. Singh from PNHP is so special to me in so many ways. The reality is we need Medicare for all. We need healthcare as a human right in this country. And it may seem like a very odd time to be fighting for this in the country, right? When we've got Donald Trump and all the shenanigans and terrible things that are happening at the federal level that are impacting all of us in our states and in our local governments. But for me, there couldn't be a better time to keep fighting for Medicare for all. We have to keep fighting. We have to fight against Medicare Advantage. We have to do what we can to make sure this system is safe enough for everybody in this country to access healthcare and affordable enough. I'm sorry I don't have teeth right now, as we know. Dental care is another real problem in this country. I will have teeth in 2 weeks. Yay, finally. It's not a matter of not having insurance. I do have insurance, and I paid all of my portion of this getting partials in my mouth, but they've been delayed because I've been going to the University of Colorado Medical School or dental school, and it's taken a while to get through that process. So I'm very happy I'm going to get through it, but it's been 336 days without teeth. That's a long time without teeth. And everything in my body has taken a hit from it. It's nice to lose weight when you need to, but not because you can't eat nutritious foods. And my protein levels, calcium, everything horribly low. But in any case, 2 weeks from now, I will have teeth and I won't look so silly. My our first guest tonight on the call is the president of PNHP. PNHP is Physicians for a National Health Program. And Dr. Diljeet Singh is, this is a big mouthful when you don't have teeth. She's a gynecologic oncologist. Anyway, it was a few years ago when I had gone to my own nurse practitioner, and she had been checking me. And I tell this story because I want all women who are of menopause age to hear this story. And nobody talks to we women very much about these things. I'm sure they don't talk to men about them either. But they don't talk to us about the changes in our bodies at that stage of our lives, right? So I assumed that things that were happening in my body were just normal. They were just part of the process. And at first, so did my nurse practitioner. And she turned around and she was gonna write a script for hormone therapy. And she said, I just don't like the sound of it. And I said, well, what would you do if it was you? She said, I'd do a D&C. I said, well, then let's do that. And it was about 3 days later that I got the call that I did indeed have uterine cancer. And because I had not known symptoms to look for in myself and had not known what might be not normal, I let things go on an awful long time. And it was a big risk for my health. And thank God for the oncologists and the OBGYN that I had, who were so very good about making sure that they not only got all the cancer, but provided me with the care that I needed to have so that 5 years later I was cancer free. So thank goodness for that. Now I did have some other cancers later on, but fortunately right now I'm cancer free. But for women, I think in that moment of life, when you're somehow being told that cancer has gone to a part of your body that's been so integral to your own being, it's a very, very difficult time. Not only is cancer itself terribly frightening, but talk about what else scares you in that moment is the cost. What's going to happen to my family? What if I can't work? For me, I was the one paying for insurance benefits at the time. So anyway, those moments in life are well defined by our healthcare system right now. And some doctors, we are lucky that some of our providers step up to help us through those moments and are now stepping up to help us change this system. And Dr. Singh is certainly one of those people. I met her years ago in Washington, D.C. We sat down and had a little bite. I think we had a cup of coffee. I don't know where we were exactly. But we chatted and found ourselves really compatible to talk about the issues of Medicare for all and what was happening. And since that time, I've made it a point to talk to my own doctors about what they're going through. The 10-minute limit they have with a patient, or the 8 minutes they have to talk to a patient before they have to move to the next one. The things that are happening are not normal, folks, and they're only normal to a broken, dysfunctional system. They're only normal here. So I want to ask Dr. Singh to give us several minutes on what's happening with PNHP right now in terms of it's Physicians for a National Health Program, PNHP.org. They are doing a research project, and I want Dr. Singh to fill us in and tell us what you're finding about moral injury in this system.
Donna, what an introduction. You're leaving me speechless because there are so many things that I feel like I could speak about I'm going to be careful and limit myself to the topic that I'm supposed to talk about. But absolutely, women and all of us in general are not taught to think about our bodies, to listen to our bodies, and to know when it's worth seeing a healthcare professional. And now, of course, the challenge in our country is even when you know you need to see a healthcare professional, you can't necessarily get to one, right? So, PNHP, as you'll hopefully a lot of you know, and as Donna mentioned, we fight for universal health care, free of profit motives, free of conflicts of interest. And I've been involved with this organization for a long time, since I was a little baby doctor. And the way we have thought about this and has changed, right? I mean, I think we still say Medicare for all, and the bill is still called Medicare for all, but let's face it, all 50% of Medicare is for profit, steal your medicine, not provide healthcare, Medicare, disadvantage, however we want to describe it. And a few years ago, Carol Paris, one of our other wonderful physician members and past presidents and current vice president, and I were talking about doing a little workshop at PNHP, and so many of those workshops are hosted by great people, like people from PDA, like people from NNU, from our great partners who are talking about the work they're doing. And Carol and I thought we would have like a little workshop on the side, just talking about moral injury in medicine. And the nurses have talked about moral injury in medicine for a lot longer than the doctors have. Doctors always talked about burnout, which kind of implied that there was something about the professional as opposed to moral injury, something that the system is doing to the professional. And just to be clear for everybody here on the call, moral injury comes from the world of the military, where it was identified that soldiers, that members of the military suffered from this traumatic spiritual moral injury when they felt like they were doing something that went against their moral code. And that thing that they were doing against their moral code was inherently connected to betrayal. Betrayal by people in charge, betrayal by people they thought should have been doing the right thing. And it's been a while now that a interesting leader in this work, Wendy Dean, started talking about it. She wrote a book. The book was called What If I Betray These Words? And that spoke to the betrayal of the Hippocratic Oath that people feel when they are not giving people the thing they know they need, when they are not able to take care of people the way they need to be taken care of, when they know that somebody who has a different insurance or with Medicaid or who has a plan that doesn't cover the right meds, that they are getting suboptimal care compared to this group, right? All of those things inherently, and I say it, and I still feel it every day, right? You lose a little bit of your mind because you know that's not the science or the medicine, and then you lose a little bit of your soul, right? Because this is not why you came. You came to take care of people. And in our little workshop, we had residents, we had students, we had doctors who'd been practicing for decades. And we had a packed room that was too full that we hadn't set up for enough people because that's who wanted to talk about moral injury. And we were lucky there was a lawyer who was part of our group, Erin Fuse Brown. You all may be familiar with some of her work that she does in helping us think about how we should actually use the laws, the corporate practice of medicine laws that are on the books, that we should get them going. She was there and she got to talking to us about doing a study, and was part of a Robert Wood Johnson Foundation advisory group and got us connected to them. And so we took on doing what's considered a narrative research study, where we've been talking to, the first part of the study was doing physician surveys. I put the link to the stuff in the chat. Doing focus groups that led to a survey that are now leading to interviews. And we're hoping that these stories will help us show people what's happening. And then the second half of our study is patient focus groups in Oregon, in Atlanta, in Chicago, and in New York City, asking the same questions. How has financialization influenced part of what we're looking at, moral injury for these patients, your experience of healthcare, your access to care, and what are the relationships between that and structural racism in our system? And as you can imagine, the stories are horrible, right? These interviews, these surveys, people just unable to tolerate knowing that they are not taking care of people the way they should. And of course, for patients, to come into a doctor's office and not actually know, what are that doctor's conflicts of interest? Is this doctor worried that she's already ordered too many PET scans, so she's not going to order that for me? Is this doctor worried about, how she is using her time and her few minutes? I've been hearing really recently a lot from patients who felt like their doctor wouldn't talk with them about much beyond the guidelines. And of course, right, we use statistics in medicine. I have a PhD in cost analysis, but we use statistics and research to help us think about how to take care of populations. But no one person's future can be told by a research project, right? And so what you really want when you go see a doctor is that they're going to use their learning, they're going to use their experience, and then they're going to know what matters to you and what your goals of care are. And all those things taken together are what's going to lead them to make recommendations to you. Meanwhile, patients don't know that they can trust that because maybe they don't have time, maybe they can only do this, maybe this is the only thing that's on my plan, and maybe this doctor is worn out and just has had too many fights with insurance companies. She's not going to take on that fight this time. And that conflict of interest just needs to be out of healthcare. You all are going to hear some more about the actual things that we can do right now, the bills that are currently in front of our legislator. But I'd also hope that you guys I'll put the link in again. If you know physicians, if you know healthcare professionals who are suffering from these things, we've even just been able to support people by making people realize they're not the only ones feeling these things when they're sitting in a room and they know they're making a healthcare recommendation that person is not going to be able to afford. And that's heartbreaking. They're taking care of people. I talked to a psychiatrist for one of my interviews recently, and she talked about how, sure, we have medications, we can help people get well on the inpatient, but they're going to be off their meds in 2 weeks because they don't have access to the care that they need, and how hard that is. And to know that we've had the science to treat some of these illnesses for decades and people don't have access to those therapies. I don't want to take too much time, so I'm going to let you guys hopefully have a chance to ask questions, and hopefully I can help you all see the need. I'm sure you're already on the call for universal health care, free of profit motives, free of conflicts of interest.
Thank you so much. I saw this week NBC, has a new nightly news host, and they're starting a series where they're focusing on insurance stories every night. And the first story they did, I don't know if anybody else saw it, was about a young man who died after his asthma inhaler had been Advair, and his insurance company would no longer pay for Advair. They dropped him down to a different product. And even at that, he couldn't afford his Advair. He couldn't get the Advair that he knew would save his life. He didn't tell his parents, he was in his early 20s, didn't tell his parents that he couldn't afford his medication, didn't pick it up, had an asthma attack and died. And I shuddered at that because I know that's exactly what happened to my granddaughter on Medicaid. And now what happens after she's been taken from Advair to Wixela, and now what will happen with Medicaid and her, who knows? So we'll have more time for questions and for comments, I know, from everybody, but these things are happening in real time to real people around all of us. And a young man died because he couldn't afford Advair. Now it's criminal stuff. It really is, in my mind, it's criminal stuff. So with that, thank you, Dr. Singh. We want to hear more about what's going on for PNHP. But for right now, I'm going to throw it over to Mike Hirsch, who is my co-partner in this endeavor with this issue team. Mike's going to introduce Cathy Kennedy from National Nurses United. I have to say I worked for the nurses for 5 years and had the joy of working in DC, and it will always be the most special time in my life. Over to you, Mike.
Thank you so much, Donna. And it's my honor to introduce Cathy Kennedy, PDA and the California Nurses Association / National Nurses United. But way back, we at PDA are eternally grateful for the support and leadership that CNA and NU always offer on healthcare policy, of course, but also on issues like workplace democracy, economic justice, and other critically important issues. We love the nurses, and the nurses mean so much to us. I'm very honored to introduce Cathy Kennedy. She's worked as a registered nurse for 4 decades plus. She must have started very young. Currently, she serves as a staff nurse at Kaiser Permanente Roseville Medical Center in Roseville, California, and she works in the neonatal intensive care unit. So you can just imagine the pressures that unit entails. Cathy is the first Black, Asian, multiracial RN to serve as a CNN NNOC president. This is her second term as a CNA president. She was first elected to the CNA Council back in 2020. She serves as a vice president of NNU. She's lent her expertise to numerous state healthcare commissions and led emergency aid missions with NNU's Registered Nurse Response Network, a disaster relief project of California Nurses Foundation and NNU. The last time I saw Cathy, she was leading a band of nurses, a large group of nurses, on the day that Senator Bernie Sanders, I wish President Bernie Sanders, and Representatives Jayapal and Dingell were reintroducing the Medicare for All legislation. And the nurses really took it up to 11 with their energy, their enthusiasm, and their chanting. It was wonderful. It's always wonderful to see the nurses. And today, as we're facing an ongoing worsening disaster in healthcare and in so many other ways, other crises that we're facing, we're blessed to hear from Cathy Kennedy. Please join us in welcoming her.
Well, thank you very much, Mike, for that wonderful introduction. And hello and good evening, everyone. Again, I'm Cathy Kennedy. And as Mike said, I'm an RN and one of the presidents of both CNA, NNOC, and NNU, National Nurses United. And as Mike said, I've been a nurse for a very long time, and I can tell you that a lot has changed since the first day I walked onto a med-surg unit 45 years ago. However, what has not changed are the core values that really define what nursing is, which is caring, commitment, and community, that pretty much encapsulate who we are and our profound commitment to our patients. As nurses, we're dedicated to ensuring that every patient gets that compassionate, high-quality care that preserves and uplifts, human dignity. As you heard from Dr. Singh, the things that really keep us all awake is that, and as nurses, we are committed to belief, and you all know this, that healthcare is a right. It's a right, and it's not just for the privileged and those that can afford it. And that everybody should be able to get the quality of care, no matter what their income, their immigration status, where they live, who they love, or any other factor. And you all know that our fractured, profit-driven healthcare system, if you want to call it that, prioritizes money, profits over patients. So there's this friction, the desire of nurses and physicians to provide care, holistic care, and then the healthcare industry's thirst for profits that we see really causes moral distress and injury that begins to take on, and it just seems to fester and grow, even though we don't want it to happen. Nursing is physical, it's emotional, and it's mentally taxing, just as physicians and throughout healthcare, because of what we do. Yet, we are willing to take it on because there's nothing more rewarding than to be able to make a difference in the health and well-being of someone's life. You know, I've been a nurse for 45 years and Dr. Singh's been around for a long time too. So this, for me personally, that's why I'm a nurse and why I've done it for 45 years. However, we didn't agree to tolerate, you know, chronic short staffing, workplace violence, the lack of critical supplies and resources. These are stressors that cause moral injury and moral distress because they prevent us nurses, physicians, to be able to give the best care that we can provide. You know, I think sometimes that, you know, how could I have watched for those subtle changes that can quickly escalate, creating additional issues for my patient if I'm assigned to a large number of patients? You know, how can I make that decision on who do I care for first? You know, how do I decide in a split second which patient gets my attention when so many need, you know, my attention as well? This is moral distress, you know, for me as a nurse. And that's what it looks like. That's what it feels like for us. Seeing patients come to the hospital sicker more than ever because they're either uninsured or underinsured with these high copays and premiums, you know. And for some, it's really impossible for them to pay, as you heard, for life-saving medication to keep them alive. We teach diabetic patients to monitor their blood sugar levels through education and teach back demonstrations so that we know that they understand how to do this, all the while knowing that there's going to be some that unfortunately will return to the emergency department with elevated blood sugars because guess what? They couldn't afford their insulin. You know, insulin was skyrocketing. We were able to get it down to $35. Now it's going right back up. Okay. This is moral distress. Patients with mental health problems seeking help come to the emergency department. What do? We stabilize them. And as Doc says, knowing that they're not going to be able to the follow-up care because guess what? They don't have insurance. That causes a lot of moral distress for us. So imagine nurses, how they feel running from room to room for 12 hours, not having an opportunity to take a break, eating your lunch on the run, and then not feeling good about the care that they were trained and provided to give to patients. You know, we feel defeated. We feel like we failed our patients. And this causes us a lot of moral distress. And we've had nurses that have actually left the profession because of that, because of all of the chronic conditions that we've had to deal with. And we all know that the profit-driven healthcare system is really at the core of this and why NNU, docs, people, this is a groundswell where we are really fighting hard for Medicare for all. As Mike mentioned, NNU was present in Washington, D.C. when the bill was reintroduced earlier this spring, and our federal Medicare for All bill includes safe staffing ratios, which defines the number of patients that a nurse would be taking care of. Studies have really shown that safe staffing ratios not only lead to better outcomes, but it also reduces nurses' moral distress and moral injury. So imagine, insurance company will no longer be able to deny care, so nurses and providers will be free to care for patients according to what is medically right and not what the insurance companies allow, right? So I would really be remiss if I didn't mention that many of us know right now that the Republicans in Congress are moving to cut Medicaid and other critical programs to fund more tax cuts for the rich through a process called budget reconciliation. So alongside of you, NNU, and our allies across the country have been fighting back against these cuts harder than ever. And we have confronted our elected officials directly while rallying people across the country to defend that their representatives keep their hands off Medicaid. If this Senate passes this bill, over $1 trillion is going to be cut from Medicaid and Medicare. And that means millions of people, millions of our patients will lose their health care. Millions will see longer waiting times, more denials as more and more services are cut. Rural and safety net hospitals across the country that rely on Medicaid and Medicare funding will close down. They will shut down. But let me just say this. Let me make something very clear. We're not just going to stop protecting what we have as we fight to preserve Medicaid and Medicare from the Republican attacks, but we also need to think about those, even with these programs intact, are still struggling to get the health care that they need. Again, underinsured, right? So we have to continue to fight for the 50% of the people in this country who have reported delaying or skipping care due to the cost. And we also need to fight for the 27 million Americans who have no health insurance at all. And we've got to continue to fight for families that are constantly having to choose between filling their kids' prescriptions or filling their stomachs. Makes no sense, right? So we're going to continue to protect Medicare and Medicaid, but we will never, ever stop fighting for a system of guaranteed health care for all, a system that never allows cost to come between a patient and the provider and the care that they deserve and they need. A system where everyone has guaranteed health care as a human right, not because they did something to earn it, but because they deserve it simply because we're human. We know that fighting against these cuts to Medicaid will not be enough to fix our broken healthcare system. We know that. Guaranteed healthcare for all people, free at the point of service, is the fight until we win. And this is the only real solution to this crisis. So nurses and physicians and many others really know too well that this healthcare system has created us this moral distress and this moral injury, which really is preventable, not inevitable. So this is why all of my union siblings and I will continue to fight alongside you and everyone else until we have Medicare for all, and we're going to win it. We're going to win it. So I'm looking forward to any questions and answers. So thank you, Mike and Donna. And
Wow, Cathy, thank you so much for those words. I recall saying to a nurse one time, I don't know how you guys don't go home and cry every night. And you know what she said to me? Yep, that's exactly what she said. We do. We do. And I thought, wow, imagine working jobs where you go home every night and cry because you couldn't get done what you needed to do. Thank you both so much. I want to make sure that we give a chance to Alan Minsky, our executive director, to say a few words tonight on the call as well. Alan, you want to, first of all, Alan's in Los Angeles, so I'd love to hear a brief update on what's going on there. But also, Alan, give us a few words about this subject, if you would.
I'm going to be very short. In Los Angeles, first of all, I'm incredibly unhappy with the unwillingness of the federal judge to grant the stay of operations for the Marines and the National Guard that have been deployed in occupied Los Angeles. People should know Los Angeles is so geographically vast. A lot of people have contacted me. I hope you're safe. I hope you're safe. Of course, I have been out at a few of the demonstrations. The over response is extreme. This is intended to cause conflagrations that the administration is going to exploit with their authoritarian drive to cement authoritarianism in the United States. So it's incredibly distressing. And of course, communities here and around the country are being broken apart in horrible ways. And I think we all need to stand in solidarity with immigrant workers in the United States every way we can to be safe and to understand too, if we go out to demonstrations and it's expected that law enforcement and ICE are there, we understand what we're getting into, and also to practice nonviolence is very important as well. First of all, I want to point out what Mike Hirsch just put into the chat, and especially thank Mike and Donna and Mike as well, Mike Fox as well. But thank you so much for all that you're doing on this. I was at a meeting this past Saturday with the the New Mexico chapter, of PDA, Central New Mexico chapter. And the discussion was revolving around the Democratic Party and the relationship of the progressive wing of the party to the party as a whole. And the question was posed, how will you know when progressives have sort of won out that the policies that the base of the party wants to see adopted, the majoritarian position of the base of the party, how will you know when those progressive positions are actually the policies that are fought for by the totality of the Democratic Party? And people were giving their answers. I put my hand up and I said, when the party not only adopts it on its platform, Medicare for all, but they fight day in, day out for it. I do think this is singular as a policy issue in the United States of America and in ways that relate directly to the eloquence of Diljeet and Cathy tonight, because it speaks to a return to a society. Return, of course, in the context of the history of the United States is always a bit of a loaded way to phrase things, but the generation of a society here in the United States and America, as great as it's promised, to quote Barbara Jordan, in which we have a caring society where individual lives are cared for in ways that they should be, commensurate with all that we understand about human life at this point. And that's simply not the case with our healthcare system. And I think both of your eloquence on the subject of moral injury has been incredibly, profoundly powerful. And thank you for joining us. So thank you.
Thanks
Thank you,
so
Donna.
much, Alan. Okay, if both of you can stay around for a few minutes, we'll see if anybody has questions or comments. If you do want to make comments about the subject of moral injury or Medicare for all issues, please don't make a long speech. We all know what Medicare for all is, or most of us do anyway. So please ask a question. We don't get these wonderful guests too often, so please ask a question of them. And I'm going to ask Mike Fox or Mike Hirsch to help me with this part of it, because I'm not very good on calling on people. Mike Hirsch, can you help me with that? Or Mike Fox?
Sure. We see Nancy N has her hand up. Nancy N, could you please go?
Yeah, thank you. I've been a pediatric neurologist for 35 years. It's a real privilege to hear Dr. Singh talk, and I love what Kennedy said as well, Donna. But I want to make a couple points. First of all, I've been fighting medical insurance companies for my patients for 35 years. I don't feel morally injured. I really feel that I'm fighting burnout. And I think so I've taken this survey a couple times, and I really think that people have missed the point that medical insurance companies are really our foe. And it really became an issue with the ACA, which was predicated on electronic medical records. And they didn't make the energy to make one good system that would be universally adopted, but it was free for all, different companies coming in, and they are designed by the insurance companies. What is forgotten is that is when 50% of physicians surveyed pledged that they were leaving practice or finding some other way to practice. Overnight, I had been one of the youngest doctors. Overnight, I had no seniors to look up to. It really was the electronic medical systems that are designed for insurance companies, and you have to play all these games to get paid. And it's been shown that American doctors spend twice as many hours in front of their computers documenting their patient visit. And that's where our time goes. And my other point is that there's some comments in the chat about state-based, and I don't really like to see conflicts within our movement, whether it's state-based, nationally based. I have my biases. It doesn't matter what you call it, universal health care, Medicare for all, whatever. We all need to be on the same team, because this is humanity, this is morality. But I think most doctors and nurses still hold on to their morality, and that it's really the work that's been pushed on us that's making burnout. Thank you.
Thank you. That's Dr. Nancy Naparko. She's part of our steering committee for this group. If you'd like to get involved as a member of the steering committee to help us, Mike Fox will drop into the chat how you can do that. And thank you for those very thoughtful comments, Dr.
Dr. Singh,
Nancy.
you want to make some comments about that?
So, well, the one thing you brought up, Nancy, that I 100% reflect, and the multi-layer problem of bringing profit into healthcare, like you said, the electronic medical record turned into electronic billing record. We lose trust because people don't know where there's conflicts of interest. Whether we describe it as moral injury or burnout, I think the point of the conversation is to say it's not because people are working, because people can't pay attention to themselves and aren't getting enough meditation. It's because the system is built in a way that doesn't allow us to provide the best health care. So really appreciate the work you're doing. Thank you for taking this survey. And thank you for being, part of this conversation. I think it is hard to really express how damaging for-profit motives are in providing healthcare, and how we've lost science, how we've lost medicine because we've lost that element of trust.
Can I also chime in here, because listening to Dr. Nancy talk about, burnout versus moral distress and injury, for me, I've been a nurse for 45 years, and I remember when we went to the electronic medical record. It was not easy, even for nurses, to understand the system, to now chart everything, all of your documentation on an electronic medical record, which, the patient's going to be able to see. So it was very difficult, and we had many nurses that, had trouble. I mean, because you needed to know how to type, as best you can, but it was a time crunch for us. I mean, when you think in terms of having, before we even, California is fortunate that we have our nurse to patient ratios, but even with 5 patients, if you have very complex patients, total care patients, the time that you spent with one patient, and then you had 4 other patients that you had to go to and then do all of that documentation, it caused a lot of stress, because then you had managers telling you there's no such thing as overtime, and you need to do real-time charting. You had issues with time management, so I think that and again, a lot of it had to do with how insurance companies were being paid. So that put the pressure on the nurses too, to make sure that we had our charting done in an effective way, and that we charted the things that would generate, revenues, so to speak. So it did cause a lot of problems for our nurses. And it really wasn't burnout. It was really stressful, and it caused a lot of, issues for our nurses. So I'll just stop there.
Mike, you got the next person?
I do. We have Melissa Richardson, one of our stalwarts, or phone banker. Melissa, could you please unmute and share your wisdom?
Yes, thank you for having me. I'm a disability rights advocate, disability justice advocate, and I wanted to say thanks to the nurses for all that they do, and they had to put up with me as a kid, going in and out of the hospital as a person with cerebral palsy. But I also wanted to bring up to always please call your Congress and senators and support the Community Choice Act, so that even disabled people can have health care for all.
It's absolutely wonderful. Thank you, Melissa. And next up, we have Nikki Leader.
Hi, everybody. I just wanted to repeat what I've said before. I have a very close friend. We met when we were toddlers, and we're both 78. Her granddaughter at 17 this past January, out of the blue, was diagnosed with something close to Ewing sarcoma. Stage 4 cancer of the kidney and stage 4 of both lungs. The kid has had one kidney removed, countless rounds of chemo at Sloan Kettering, enormous amounts of transfusions and white blood cell replacement. And her insurance company denied paying $10,000 for a treatment that would help her not have her alimentary canal ruined by the chemo. It's just unbelievable. And the kid is in so much pain, she has to have epidural painkillers. She's struggling for her life. And this is a 17-year-old. Her father's a doctor. Even his insurance doesn't cover what she needs. And I just want to know, what's with the health care for our congressmen and senators? Do they get this shit handed to them? Pardon my potty mouth. Are they denied care? Are they denied?
Thanks, Mickey. Wonderful question. Does anybody want to take that question?
Well, they actually do. We provide, I know you'll all be happy to know, we provide them with good benefits. One of the things that really annoyed me when I was in DC, did you know that every single congressional office has its own health office? Did you know that? And if one of those congressmen has a sore throat, or he doesn't feel good, or she needs needs physical therapy or something, they go to the health office. Wouldn't that be nice? You like to do that. They know what it feels like. Believe me, they know what it feels like. But they have plans that we provide for the congressional health plans. They are much better than most of us will get. They are better. Their staff do not get the same level of health plans, but congressional members get a pretty good plan. So don't worry about them. They're okay.
I just want to make a quick comment, though. I was just reading through the chat as fast as I could, and just thank you for those of you guys who shared your hard stories. It is so difficult. And being sick and knowing that those things are out there and not being able to access them, and like Cathy said, having to make choices. Every single one of my patients makes a financial choice every day, whether it's filling a prescription or you're paying their copay for their MRI. But every single day, one of my cancer patients will bring up the decision they're making, or why they skipped a treatment, or why they put something off. And the fact that we've made those things equivalent, right? Something you buy versus taking care of your health. Yeah. I just thank you for sharing your stories. They provide inspiration to me, as I'm sure they do to a lot of people on the call.
Absolutely. And we do have a lot of people with their hand up. So if we can get to the question right away. And we have Heidi. Please unmute and ask the question. We have Jeffrey on deck.
Hi, I have my own sob stories that I can share, too many of them, but I don't want to go into that because I feel like it's important to raise a question about the way that Trump is handling our healthcare issues, especially with Robert F. Kennedy Jr. cutting out the vaccination. And I'm wondering if that vaccination group, and I'm wondering if there's any way that any of you can maybe help to do what they did with the Alt National Park Service, where everybody from that committee gets to stay on in some capacity, in some, maybe not some governmental form, but some alternative working force, so that we don't lose their brain knowledge, and we keep their information flowing, so that we don't have a backslide in our healthcare. Does that make sense?
I am familiar with that Alt National Park group. I think it's kind of unofficial. It'd be interesting if somebody like Bill Gates, who has billions of dollars, were to hire them and keep them on. I know that he's been supportive of vaccines in general, but I don't know him. If anybody happens to run across a billionaire or somebody like that, it'd be terrific to have somebody step up and fill that breach.
Could anybody reach out to Bradley Whitford and Elizabeth Warren, who were friends with Adie Barkan, the Be a Hero?
Sure. Somebody, are you working with Be a Hero Foundation?
Me? I
Yeah.
wish. Not
Okay.
very, but
'Cause
I
I think-
could reach out to somebody from them.
Okay, I think somebody on the Zoom mentioned that they did work with that foundation, and if not, we
Well,
can
that
always
was-
reach out to them.
That was probably me earlier that I said that I had posted a lot of things on Facebook about them.
Okay,
But
maybe
no,
that was it. Well, that's
I-
a great idea. We can definitely look into it.
So I just feel like we need to keep these brain trusts together, and not just for this one committee, but for all of these things that are being taken away in our environmental issues too. But I know we need to wrap up the call,
Yep.
so I don't want to talk anymore.
But that's a terrific suggestion, and I appreciate that a lot. If the doctor or the nurse wants to chime in at all. And I also want to give a shout out to Carmen Comsty, who is with us tonight as well. Welcome, Carmen. And
Let me just say that I agree with what you just said, Heidi. You know, I think it's important because that's knowledge. These are experts, you know, and working in the NICU for many years, I had mentioned this before we came on board. The vaccination information sheet is something that we actually give our parents because, you know, our babies, the preterm babies stay in the NICU sometimes for several months. So they may get their first set of vaccinations in the NICU. And so we have an information sheet, vaccination information sheet that is provided by the CDC. And it's a wealth of knowledge. I mean, and to see the president or see Robert F. Kennedy just fire all those experts is very disheartening. So I think your suggestion is a good one, but you know, it's a valuable resource. So yeah.
well, somebody made a mention in the chat, Cathy, that you should be the Kennedy who's in charge of HHS. So they got the wrong Kennedy in there. But we'll continue.
Love to replace him.
And we would all love to see that. Jeffrey and James, you're on deck.
Yeah, Cathy, this is Jeffrey in Sacramento. And I grew up with Ruth Halbrook when she became a nurse, and I believe was up there at your Roseville.
I know Ruth well.
Yes. Anyway, just small world. Right now, I will offer is for the Kaiser South Sacramento has had to take a patient because the inner age supplying for the COPD, the inhaler.
Yeah.
3 times he's had to go to the hospital because they failed to realize what, this is just standard service, and PACE, like InnerAge, doesn't do the job to make sure. And so he's been to the hospital. Finally, Kaiser has said, this is a pattern. We need to see that it gets handled correctly. Just a heads up to you guys of something else that's going on currently in our existing system. Thought it would be worth mentioning to you, and keep up the good work. I was on call before this one, and I'll be on at 7:00, another call. So we go from there. Anyway, my name is Jeff, and I'm here in Sacramento. And yeah, Ruth retired from you. So anyway, take care.
All right. Thank you, Jeffrey.
Okay. Yeah, no, we're hearing a lot of stories about huge gaping holes in the current system. And James, you're up.
This is Harriet. I'm with James, and both of us are mental health professionals. And I wanted to talk about an issue that happened to me years ago. I'm a retired mental health professional. I'm a retired professor of counseling and psychotherapy. So this happened back when I was still in practice. I would have a suicidal client who may need to have 2-3 sessions a week, also involving the family. And the managed care company would only allow 1 or 2 sessions a month. To get the person through the suicidal crisis, I needed to see not only that individual for individual therapy, but also involve the family in ensuring his or her safety. Hospitalization was out of the question. I supervised interns during my almost 20 years of teaching who also encountered similar issues with managed care companies regarding increasing the number of sessions that their suicidal clients could have.
Yeah, I think that we'd all agree that mental health is still stigmatized and underfunded and underaddressed. And we're very honored to hear from you. And thank you for sharing your experience. As dismal and upsetting as it might be, that's important for us to know. And the Medicare for All legislation will cover mental health care as well as dental and long-term care and a lot of other things that aren't in traditional Medicare. So it's very apropos that you brought that up, and I'd love to hear from our guests what their
Well,
comments are.
I know that myself and my colleagues often would provide pro bono care just to get a client out of a suicidal crisis.
But thank you so much for doing that. You shouldn't have to, but you did, and thank you so much.
Well, and now the world is so complicated in that it's
did we
really,
lose
really
Mike?
challenging
We
to
might have
even
lost Mike.
pay for.
You there, Mike?
Donna, we could hear you. Can you hear us?
Yeah.
Okay, good. Sorry
Oh,
about
I
that,
was just
doctor.
saying, no problem. I was just saying that now it's really challenging to even try to provide pro bono care, right? Like the complexity of trying to submit a no charge anything. Or, we have these global fees after people have surgery. They should be able to get follow up for 3 months. And if it gets to be 3 months and another day, literally it'll be challenging to get them in to be managed for a post-surgical complication. The world has just changed in such a painful and dramatic way. I finished med school in 1991, and I remember the days when we were thankful that somebody was 65 because we knew we wouldn't have to deal with prior authorizations, et cetera. And of course, all that has changed. But I want to give everyone time to answer their questions. And thank you, Harriet, for the work you did in the comment.
I guess we'll move on to Scott. Your question or comment, please.
Hi. First, I'd like to draw attention to the effort in the state of Washington by Patty Cooterer, our newly elected insurance commissioner. She is working in concert with another group called Whole Washington, who are going to be trying to get a ballot initiative passed next year to get universal health care in the state of Washington. Patty also has some ambitions to make that a cross-regional effort because we already basically provide a significant portion of Alaska's needs up in Washington because they don't have the specialists. My question is, my sister is a medical biller, and she has been dealing with this problem where insurance companies are constantly changing the procedures to make it harder and harder to actually get paid as a hospital. And I was wondering if you two had any insight on how to stop this bureaucratic arms race from escalating where the insurance company makes their procedures a little bit more esoteric to get paid, and then the providers have to hire people to then comply with whatever insurance system there is. And that dynamic is, I think, under considered.
Well, I'll just quickly say, take the insurance company out of the equation, period. It's the providers, that it should be the provider and the patient that talks about the care that they need and when they need it. it shouldn't be an insurance company looking at an algorithm saying, okay, you know, because of this, I mean, you know, they go through that whole process. I mean, it's ridiculous. So.
I mean, 100% agree, Kathy. The thing I said before, making our system a for-profit system introduces all these layers of different ways to game the system, different ways, you know, the issues that Dr. Nancy raised, same thing of different gaming that happens in the electronic medical record. I 100% agree, Kathy. We just have to take the profit motive out of the system.
Absolutely. You know, they do it for our Congress people, right? They can do it for us.
Amen. We're at the top of the hour, so we're going to try to power through. It's a little late here in the East, so we're going to try to do it before my bedtime if we can. Rick, if you could share your thoughts, your question or comment.
I think I'm unmuted. I wanted to thank Nurse Kennedy, and I'm going to massacre your name, Diljeet Singh. But PNHP has been in this battle since they were founded in the late 80s. I'm glad that we're in the battle with them, but the whole problem is so easily resolved by getting rid of the goddamn insurance companies. And until we do that, they're putting more red tape, and we're getting less patient care and burning out our medical professionals. So we don't need no doctor that's got board certified needs some bean counter or jackass in the insurance company telling them how to provide patient care. And the reason our patient care is so crappy is they waste so much doctor time and administrative bureaucracy. And that's why hospital rates are high. The hospitals have armies of accountants just fighting with the insurance companies to get paid for having patients in the hospital. So we need to change the system where patients are the important thing instead of profits for the insurance companies or for-profit, semi-for-profit hospitals and other big entities, big pharma. Right now, we're at the only thing that they're interested in from us is being able to bill for co-pays and premiums. But the actual care for us is irrelevant.
You definitely get it, Rick. That's very well said. Thank you so much. Do our guests have anything to add at this point? Love to hear it.
Totally agree. Totally agree.
Great job, Rick. Thank you so much for
Pleasure.
summing it all up so well. Chris, if you would like to give us your comment or question. Okay, you're unmuted, and I heard something while we're waiting for Chris.
Can you hear me at all?
We can hear you, Chris. Thank you.
I'm sorry. I'm not computer savvy. I just had a simple question, complex answer. What's going to happen when AI takes over everything and I'm talking to a machine when I want healthcare?
Great question.
Well, you know what? We're actually fighting that, Chris, because we really, you know, again, this goes back to health systems. You know, they're looking at ways to, you know, use less labor and more, you know, technology. I mean, while that's, you know, all the bells and whistles is great, but really at the end of the day, you know, we are saying it is so important to have an actual person. You know, how is it that you can provide care for if you're not really, you know, a human being, somebody to sit at the bedside, hold your hand, you know, talk to you, all those things. So, you know, we have been paying attention here in California and across the United States when there are any kind of bills that, you know, AI is introduced and looking at trying to replace an actual person. So we are fighting that, and we are educating, you know, our nurses all the time, you know, and in our collective bargaining agreements, we have language that says if there's any new technology that's being presented, that the nurses have a right, you know, to be at the table to talk about it, to see if it's something that's really necessary, because a lot of the stuff, you know, AI, the technology is unproven. And it has been untested, and we do not want our patients to be the guinea pigs. So we are fighting back.
And we know, right, that AI is being used currently to generate denials to maximize the ways that insurance companies can profit. And the other issue with AI in healthcare, certainly we know, you know, we have never done good research on minorities. We've never done good research on women. All our data is so flawed. So to imagine that we take this flawed data and feed it into an AI and think that it may give us good answers for how to take care of people doesn't make sense. But it is already happening, and it is very, very much a part of American healthcare. And it shouldn't be. 100% agree. I actually have another call also. I'm going to sign off in a few minutes. I just want to let these last couple of people take their and put in their questions.
Thank you. Mickey's already gone, so I'm going to have Chuck Pinocchio go, and then we'll have Mickey close us out. Chuck is a great friend of mine, working with One Pair States. Chuck, please say a few words.
Yeah, thanks, Mike. It's been a real pleasure to listen to so many dear friends tonight, and hopefully connect with a new friend, Cathy Kennedy. Really, really delighted to listen to you. Diljeet, you know, your presidency of PNHP, you're a wonderful leader. Donna Smith, we go back so many years. Thank you so much. And Alan, I just wanted to just alert folks, because the PDA audience here is very supportive of the approach to getting to Medicare for all, national Medicare through the states. And I'm an agnostic too, like so many people in this audience. I'm an historian, a longtime organizer. There are so many states that are leading the charge: California, Oregon, Washington, New York, Minnesota, Maine, Pennsylvania, Massachusetts. I'm an opportunity-focused individual and just want to support the effort. Soon, Ro Khanna from California and Senator Markey from Massachusetts will be reintroducing the State-Based Universal Healthcare Act. Just want to put in a chime for that and a plug for that. You'll be hearing more in the next, I think probably the next few days, actually. That bill will be reintroduced. I know what we face as a nation. I'm an historian and a 50-year organizer. But nonetheless, you know, we're all about radical hope. Eyes wide open, radical hope, eyes wide open. We know what's in front of us. We've got a strategy. We've got a way to get this done. And with the nurses, with PNHP, with PDA, and all of our allies in the fight, we look forward to getting to national, improved and expanded Medicare for all. Very excited to be with you all. Thank you so much, Mike, for bringing me up. Appreciate it. Thank you so much.
Thank you so much, Chuck. And PDA, as a co-founder of One Pair States, is very excited that Ro Khanna and Ed Markey are going to saddle up and put forward this legislation again. And like Mike Fox said, we just want to get there. And as Dr. Nancy said, this is a unified movement. We're all in it together, everybody in, nobody out. Right. Shoulder to shoulder, and we're going to get it done.
That's right. Okay.
Dr. Singh, are you still with us? Do you want to give us a few?
How can I top Chuck? That was great. Yes, absolutely. We know the answers, and we're going to get there. Why? Because we have the people power.
That's right.
So I cannot say anything more to that. Thank you, everybody, for caring. Thank you, everybody, for listening tonight. My pleasure. And yes, we will get there.
We would love
PNHP docs and NNU nurses give we patients a lot of hope, and a lot of reassurance that you really do give a damn about us, really.
We do. And we're not going to stop.
Thank you for that. Thank you for that always. Thank you for being on this call tonight. You guys are amazing.
Yes.
And we'd love to have you back in a few months. We're going to be doing this every month, second Tuesday every month. You're welcome to come anytime and share what you're working on.
Okay.
We love you so much, and we respect and appreciate your commitment and your leadership. So thank you so much
Thank you
for
for the invite.
everything you do.
Thank
Okay.
you.
Sign off now. Thank you. Thank you.
All
Thank you.
right.
Okay.
Thank you. Good to meet you all.
Bye.
Bye.
Bye.